Good day and welcome to ISSUP South Africa webinar entitled Panda, the Perfect Digital Companion on the Road to Recovery. Just a bit of housekeeping. Please, on the control panel on your right-hand side of your screen, you'll find a question box there. If you have any questions during the broadcast, please feel free to post them in that question box, and we will hopefully get to them towards the end of this session. Thank you so much for joining us. We look forward to a great webinar going forward. So the onset of COVID-19 and the worldwide lockdowns that followed has hastened a revolution in the manner in which people access services, particularly those who promote healthcare behavior change interventions. This revolution, however, is not solely credited to COVID-19, however, as there were mobile applications and web-based apps in operation prior to the pandemic. However, these applications became more relevant during the global pandemic. The Global Observatory for E-Health of the World Health Organization classes these interventions within what they call mHealth, which is further defined as medical and public health practice supported by mobile devices such as mobile phones, patient monitoring devices, personal digital assistants, and other wireless devices. mHealth is bringing about a change in the way that in which populations access health and mental health services. These apps can have tremendous advantages that we are only beginning to understand. They also have an important role to play in the modern world where access to facilities and access to free time is limited for a large portion of the population. Furthermore, mHealth can also be seen as an important preventative intervention when assessing health or mental health problems. For example, Joseph et al. 2013 suggests that the use of internet-based technology has several benefits for interventions that promote physical activity, including 24-hour access to intervention materials, the low costs of implementing the internet-based interventions without experiencing the delays that are expected with print-based interventions. However, it is also important to note that these mHealth applications must be informed by experience and expertise to be able to have the desired impact. What we present today is an example of one of these platforms that is active within South Africa at present. Panda has been developed and implemented by mental health professionals and is informed by theoretical practice. Please note that this webinar is provided for informational purposes only and does not constitute medical or treatment advice. The views presented here are those of the speaker and not necessarily those of ISSUP. So without further ado, I'm going to introduce our two speakers today. Allan Sweidan is a registered clinical psychologist, psychotherapist, and entrepreneur. Allan worked in the public sector in South Africa before moving into private sector with a special interest in dual diagnosis treatment in the early 2000s. In 2007, Allan founded the Akeso group of hospitals, which by 2018 was treating up to 22,000 patients per year, about 15% of whom also suffered from at least one addiction. In 2021, Allan co-founded Panda with Alon Lits, the outgoing director for Uber in Sub Saharan Africa. Panda offers unique features within the crowded mental health app industry, offering benefits to general users of the app, mental health users, medical schemes, corporates, EAPs, and other employees. He is joined today by Kerry Howell. Kerry is an occupational therapist with a passion for mental health, especially when it comes to making sure that those who need help find their way to the right care. Kerry brings her years of clinical and corporate experience to Panda, where she dedicates her time to making sure every Panda user enjoys a meaningful experience within the app. An avid mental health scientist with a recently obtained master's degree, Kerry believes that occupational therapists are the superheroes in society. And it would seem that those at Panda completely agree with her. Very warm welcome to you, Allan and Kerry, and we look forward to your presentation. Thank you so much.
Thanks very much, Roger.
Great.
Yeah, thank you. Just a quick check that everyone can hear me. Can someone just confirm that you can hear me and see me, and that everything is good? Okay, good. They say that webcams are like the modern day seance, where they always start off with, can you hear me? Can you see me? So I agree with that. So yeah, first of all, a really big thank you to ISSUP, to Roger, to Olivia, and to David Baeva, who I haven't seen on the call today, but who really introduced the idea of ISSUP to me. It's really, we feel honored to be able to present to you, and we really appreciate the opportunity. And then just say a special thank you as well to Kerry, who really is such an incredible part of Panda and who helps me so much with these presentations. So thanks to everybody. Just some personal background. I'm a clinical psychologist. I've been qualified since 1998. My first roles in the industry were in dual diagnosis treatment, or it was really an addiction, but from the very beginning, I started to work with the concepts of dual diagnosis, of harm reduction, and those are the concepts that made the most amount of sense to me. And I'm sure we can debate those later on in the webinar. I started off treating patients in my practice in primary care, and then moved into a hospital setting because in Johannesburg at the time there were very few rehabs. There were no psychiatric hospitals, and there was this huge problem where if a patient came to me and they were at risk, there was nowhere really to put them in a place of safety where they could get treatment. And I wanted to just talk very briefly about what happened during COVID. And then I want to talk a little bit more about this idea of risk, and then we'll go into the Panda overview. But I worked inside the mental hospitals. We started off with one hospital in Joburg. We ended up with 12 hospitals across 13 sites through the country. And as Roger said earlier, we were treating up to 22,000 patients here in about 1,000 beds. The average length of stay was about 11 days, and the average length of stay for someone with a dual diagnosis went up to about 17 days, which is very different from the original days in Johannesburg of treatment, where the community centers would house people for up to a year. In these therapeutic communities where they sort of were detoxed and then really kind of rehabilitated in the true sense of the word. So you can get a sense of what's happened with funding in South Africa, as I'm sure it's happened everywhere in the world, where we're being pressurized to detox a person, get them onto the right kind of medication, get them into the right psychosocial program, and then to discharge them in a very short space of time. And that's what we learned to do pretty well in the hospital setting. Where we really understood the limitations, and that what we're trying to do overall was to de-risk a person and to make them more functional in the very brief time that we had with them, which, like I say, was about 17 days for people with a dual diagnosis. And then in that context, all we really tried to do was to change the direction of the momentum of their lives. So when they would come and see us, they were often in some kind of free fall, psychologically, socially, and then in terms of their own health. And what we would try and do is catch them, detox them, understand what kind of underlying issues existed in their lives, whether they were biological, psychological, or social, start to address those issues, and then place them into an outpatient program. And I actually used to always think that people were very lucky in a sense if they were addicts, because they would have a context in which to go into once they were discharged from hospital, where most of our patients had no context. There were very few outpatient support groups for depression or anxiety or bipolar or even for eating disorders. But when it came to narcotics addiction or an alcohol addiction, patients could go directly into an NA or an AA program. They could start off with 30 and 30 meetings in 30 days, 90 and 90, and then try and get that first year of being clean under their belts. There was also the idea of sobriety kind of uber alles, where that's what we went for. We went for that a person had to abstain from any medication that wasn't prescribed for them or any street drugs for the rest of their lives, but obviously one day at a time. And although I think we sort of preached that, I think that there were times when we had to kind of compromise and find a way where people would sort of, choose harm reduction, even though we didn't call it that. But I'll just give you that as an introduction. And then the other thing is we absolutely did believe in psychiatric medication. So there was no concept of sort of that antidepressants were, in any way bad. Although obviously we try to keep people off benzodiazepines or any kind of addictive medication. What happened during COVID, which was really interesting for me, what happens over the last couple of years, which was really interesting, is that COVID sort of exacerbated the mental health problem, where I think that although it was pretty bad in South Africa and I think worldwide, the statistics are that sort of about 15% of any population around the world will suffer from some kind of psychiatric illness or addiction in the course of any year, with a lifetime prevalence of about 30%. And that up to 80% of those people are never getting any kind of treatment at all in South Africa. And even in a very developed country like the United States, we believe that it's about 50% of people who need some kind of mental health care never get any, basically as a consequence of stigma and cost. And the thing that changed during COVID that I found so interesting was that a lot of treatment professionals who would never have moved onto virtual platforms were forced to move onto virtual platforms. And what they found is that it was okay, that it wasn't treatment as usual, but that they could continue to work with a lot of their patients, and that the outcomes were perhaps not as significantly different or worse as they thought they might have been. And what we're finding even now is, as we moved out of a COVID environment and back to a kind of a normalized environment, is that a lot of therapists are still choosing to use hybrid models of both virtual practice and in-person practice, because it's just so much more convenient in so many different ways, where if a person is away or they have some kind of cold where they think they might be contagious, they don't have to miss a session, but they can continue to have a session on a platform like Zoom or something like that. So this virtual platform became much more acceptable as the mental health the need for mental health care exploded, which were two really big consequences of COVID, which we're still seeing now as people are adjusting back to a new normal. And then the other thing that sort of was of real interest to me was something that I always used to work on in the hospitals, where what I came to understand is that it didn't really matter to me why a person was admitted in terms of their diagnosis. It didn't really matter to me if they came in with a diagnosis of depression or bipolar disorder or an anxiety disorder, or let's say an eating disorder was a bit different or an addiction was a bit different. But what I really kind of realized is that what I was treating primarily were the risk factors associated with those diagnoses and the functionality factors associated with those diagnoses. And the third factor, which was perhaps as important but less measurable, were the internal levels of distress. But these three factors, risk, functionality, and distress, were actually what we're trying to treat when we were treating patients, because, most psychiatric illnesses are chronic. And there will be ebbs and flows, and there will be relapses, and there will be periods of calm, and there'll be periods of good health, and there'll be periods of relapse. And I'm not saying that one accepts that. What I'm saying is that one has to kind of work with that when you've been in this industry for a very long time, and understand that really what you're trying to do all the time is to de-risk a person. And when I talk about risk, primarily what I'm talking about are suicidality, self-harm, psychosis, addiction to substances, and alcoholism. Those are the 5 major risk factors that I would think about. And self-harm is quite broad, and I would include lots of factors in that. But when a person is self-harming themselves through eating, in a particular kind of way, or cutting themselves or burning themselves, whatever it is, it all falls under this category of self-harm. So I was trying really to de-risk that person's behavior and at the same time increase their functionality. And functionality would be primarily in 3 areas, which would be their capacity to look after themselves, to be able to get up, get dressed, and just have some measure of self-care, and have a relationship with their own health and their own self. The second category would be to be able to work effectively, to not have to use substances or anything else to have to work effectively, but to have meaning in the work that they were doing. And the third factor was really around their loving relationships or their relationships at home, which is where they're able to love and to be loved in return. And you can break that down into however you want to ask those kinds of questions. But for me, those are the 3 real factors that we worked with when we talked about functionality. And the interesting thing about risk and functionality when one moves away from the DSM-4 and towards the DSM-5 is that you can start to measure those issues. You can, so instead of, just using the PHQ-9 for depression or the GAD-7 for anxiety, you can actually now start to measure risk and functionality and understand that a person's levels of depression may increase or decrease, but that doesn't always have a correlation with their risk profiles and their functionality. And really what we're trying to do all the time is to build up those risk profiles, is to decrease risk and improve functionality and measure that along the way. And the other thing that I really learned is that one can't improve in one's own methods if one doesn't measure where one is at and understand what one is doing as a treatment professional or treatment provider for the people that are coming to us for treatment. We need to have a starting point, and we really need to measure so that we can improve. And those things became much more easy to do through the publication within the American Psychiatric Association of their cross-cutting measures, where now and with the publication of the HUDAS 2.0, where you can now use these free, reliable, and valid tools to measure a person's progress away from these, I think, quite esoteric concepts like addiction or depression or anxiety. Not to say that those things don't exist, but I'm saying that those things are quite hard to measure, because one of the questions that all of you as treatment professionals will face every single day, I would imagine the way I did, is when does this particular kind of use become a problem? Because you have people who sort of drink a bottle of wine a night and seem like they're absolutely fine, and then you have people who are using a bottle or drinking a bottle of wine a night and are seen to be, alcoholics. So when does it become a problem? And I think it becomes a problem basically in terms of risk and functionality. That's the way that I've come to think about it. And that's very much what underpins the philosophy of Panda in what it is that we're trying to achieve. If I just talk very briefly about Panda, and then I'm going to ask Kerry to run through a presentation, is that Panda, the way that it was designed, is it was designed to address why people don't get mental health care. What is it with those 80% of people? Why don't they get mental health care? And what we really kind of, when we dug deep and we did all the research, what we understood is that the 2 biggest factors were stigma, and there's self-stigma and there's social stigma. One has to get over the stigma within oneself of admitting to oneself that there is a problem, and not, immediately trying to get rid of that, but trying to work with that narrative. And then there's the stigma that happens socially, especially with addiction. And then there's access. And the problem with mental health care is that there's no real triage process. And so people don't know how to access the system. And because they don't always know how to access the system is a very inefficient one. And if one just thinks about somebody falling and breaking their arm or hurting their arm on a sports field, in, let's just say, any country with reasonable health resources, that person will be taken to a clinic or to a hospital casualty unit, where they would be excuse me, first assessed by a nurse. The nurse would look at their arm and either realize that it was just bruising, or they would ask a doctor to come in. The doctor would then come in and then look. So the nurse might actually discharge that person with a couple of Panado or an anti-inflammatory. If the nurse is not comfortable, they'd ask a doctor to come in and look at it. The doctor might also then either confirm what the nurse thought, which is that this person can be discharged, or they might escalate it to x-rays. That person then might have x-rays, they might see a fracture, and they might be referred to an orthopedic surgeon or whatever kind of surgeon is required in those situations, and then the treatment can follow. But there'd be a clear triage process. Whereas in mental health care, there just isn't that. There's no place where you can go to, generally speaking, and be properly assessed by someone in such a way that they will help you to enter into the system. And so what happens is that people enter the system in a very ad hoc kind of way, where they either know a friend, or they go to their GP and they get referred to a clinical psychologist or to a psychiatrist. But often those referrals are not appropriate. They end up being very expensive and not exactly what the person is needing. And for both the user and for the provider, that's not really the ideal situation, because providers want to be acting at the top end of their scope of practice, not at the bottom end of their scope of practice. A pediatrician doesn't want to be treating sniffles. They want to be treating serious illnesses. In the same way that a psychiatrist wants to be treating issues like bipolar and schizophrenia, and doesn't want to be treating somebody who is necessarily, let's say, having existential issues. That should go to a psychologist, and then even then the psychologist should try and understand, is this a deep-seated trauma, or is this something that can be treated by a social worker or a registered counsellor? So there should be a triage process, and that's what we've really tried to establish within Panda, is that there are these different levels of care, and there are very many different kinds of assessments that help all of our users to access the system in a way that feels efficient. The last thing I'm going to say to you is just, our interest today in pitching to you is we want people to use Panda. The Panda app is, for all intents and purposes, free for users and for providers. We want you to use the platform. You'll get a demonstration of it now, and the platform gets better the more people use it. So the more that you can encourage the people that you treat to use Panda as a post-care or a pre-inpatient care platform of care, that's better for us. And the more that the providers out there want to use what you'll see is the forest as a platform for providing services, the better it gets for us. So that's really our pitch. We want you to use Panda. It gets better, and the more that it gets better, the better it is for us, and the easier it is for us to sell some of the data on an anonymized and aggregated basis. So we never give away any kind of personal information, obviously, but what we can do is we can collect data, and we can see what works by measuring how people do the assessments, and understanding how they've interacted with our app. We can really develop an understanding of what works in mental health care, which I think in many ways for me is the holy grail, because there just isn't a lot of research out there. On that note, I'm going to stop talking and hand over to Kerry for the Panda overview, and then a demonstration of the app, and then we can take questions afterwards.
Great, thank you, Al. I'm also going to just check that everyone can hear me.
We can.
You can hear me and you can see me. Can you see the presentation? Al?
We can see it.
Okay, fantastic, great. Good morning, everybody. As has been mentioned, my name is Kerry and I'm an occupational therapist. And I'm just really going to be double clicking on a few things that Alan has mentioned. I'll be taking you through a demo, and then, yeah, we can open it up for some questions. So our real big focus at Panda is democratizing mental health care, and I hope by the end of this you'll be able to see how we are doing that. And obviously what Al was mentioning about the pandemic and that just exacerbating an already existing problem is something that I would expect most of us on this call to be very familiar with. And so, yeah, as we know, the World Health Organization has estimated depression to be the leading cause of disability. And that's, yeah, really looking then at low to lower middle income countries. So, yeah, when we kind of think about this problem, it's really far reaching. And I think as Al has articulated, and as I've said, I think a lot of us on this call are familiar with this prevalence and just with the importance. And so, yeah, with that in mind, there are three main factors limiting access to mental health care. And Al touched on the stigma, on obviously triage, and then particularly within South Africa, cost is a limiting factor. So if we kind of look at the stigma aspect, how we built Panda is really looking at removing the stigma by allowing users to have an anonymous profile. And so once we're in the app, I'll be able to take you through exactly what that looks like. And this obviously provides for that safety and really just lowering that barrier for people to be able to access the mental health services that Panda provides. Then looking at cost, so within South Africa, as I mentioned, there's a particularly high cost to private healthcare, and then we also have state healthcare, which although has a much lower cost, has a very, very high waiting list. So the waiting lists are very long to get mental health care. And yeah, unfortunately, we really are yeah, at a loss kind of on both sides. And so what we then look at within Panda is what are some services and products and care really that we can be providing users that are as cost effective as possible. So again, I'll take you into some specifics around that as we go along. And then Al was mentioning the triage, so really just focusing on the right care at the right time. And if we look at the continuum of severity and what the different healthcare services and support is available, and we actually have a slide which just pulls that out a little bit further, which I'll get to. And then, yeah, looking at, I guess, this idea of scale, which, yeah, you know, I think Roger was talking about e-health and m-health and kind of the research that's gone into that. And so we obviously at Panda are really leveraging this kind of concept of mobile healthcare where it's in the palm of people's hands. And obviously, you know, with making sure that this is quality mental health care, if we think of then an analog solution where, you know, we think of Alan's story of going from a very one-on-one, you know, patient-based, practice-based, individual practice-based setting to what he built with Akeso, where we think of this clinic of rehabilitation, and then now looking at Panda, where we actually having a look at a technological solution that can be scaled globally to really start moving people along to what we see as proactive preventative care, while still bearing in mind that there is a time and a place for your more reactive one-on-one kind of care. So yeah, I will again come back to that. But just some more context in what we were doing. I'll touch on it briefly around looking at just this concept of measuring and this data. And obviously, I think, you know, again, those of us on the call, we're very familiar that it is hard to quantify mental health, behavioral health, and hard to measure these things. But with what we're doing at Panda, we've got a really, really strong arm around data collection so that we can be increasing our ability to analyze and be responsive to what we're learning. And this really creates a flywheel of us being able to iterate and improve as we go along. And so, yeah, you know, it kind of is summed up in the heading of the slide where it says increased product engagement leads to increased data collection opportunities, which creates a more proactive environment. And so on the right there, we see the increased data collection, which I've mentioned, and then the improved interventions. Obviously, like I said, I'll take you through what our interventions exactly are. And then there's obviously community growth. And so at Panda, we are actually a two-sided marketplace. So we obviously are a marketplace for users. So that is mental health users across the spectrum of severity, from those just having a bad day right up to those in crisis. But then we're also a marketplace for mental health professionals. And again, that goes from looking at your lay counselors right up to yeah, your specialists in any kind of mental health expertise. And so over time, you know, we really and already are fast becoming the go-to community for mental and behavioral health resources and care. And so our mission, which you would probably have heard by now me mentioning and Al mentioning, but just really to call it out on a slide, is to ensure that everyone has access to the right mental health support and resources at the right time. And then our vision to be the go-to community and marketplace for mental health care and content. And I think, yeah, before I go on, I'd actually just like to double click on this right care at the right time, and picking up on that triage and that data assessment piece that both myself and Allan mentioned, is to really say that what we're trying to do is, as we are assessing users' engagement in the app, as you know, that's through just generally what they are expressing, but then actual clinical assessments that they're completing. How do we then respond to that and push them to the right care at the right time? And so, yeah, this kind of is one of our key diagrams that depicts what we do and how. And so I've mentioned to you this severity spectrum, and if we overlay that with a frequency spectrum, we can really understand what each product within Panda is. So we have our forest, which is at the bottom of this pyramid, and this is our core feature where we see obviously the most high frequency, but also then the low severity. And what the forest allows is for there to be this one-to-many aspect where users are able to come in and receive community support from other mental health users within group sessions, but then also to connect with a mental health professional who is a live professional. So yeah, it really is something that is not only accessible but tremendously valuable for people, and something that can then be scaled to really be able to reach many people, and they can just keep coming back to that as they go. So yeah, that our forest at the moment runs for actually more than 12 hours a day. We've recently just opened the forest to be more hours. So at the moment it's 8 a.m. until 10 p.m. At night from Monday to Friday, and then on the weekend it's the 10 a.m. to the 10 p.m., which is the 12 hours. So yeah, I'll get into a little bit more on the forest, because that's obviously one of our biggest differentiators, and something we'd love to hear your comments and questions on in later slides. But just to finish this off, we've obviously then got our life skills training. And so this is looking at content that lives within the app. So it's videos, articles, activities that people can complete to be able to improve their life skills, to better cope with things that they are navigating. And then we've got the text-based chat support. So I think, yeah, particularly within the South African context, when we look at what I was referring to earlier on about this cost factor, what we see with the text-based chat support is that it is a means to lower this barrier as well. So we've obviously got the forest and the life skills training, which is free, but text-based chat support has a small price on it, where users are then able to have sessions that are texting. So it's like a WhatsApp chat basically with a mental health professional on non-clinical issues, so that they can really be guided, supported, and then obviously referred on if need be. And then we've got the expert sessions. So this is obviously one-on-one sessions and really telehealth as we know it. So mental health professionals can register on the app and create their own profile. And this obviously then is for those users who are needing to go deeper, where the behavioral patterns, thinking patterns, mood, whatever it is that is needing that more one-on-one expertise and specialized care. That, yeah, they can then access that. And with the mental health professionals that we have, a big thing that we are promoting is to really just start exposing mental health users to the range of mental health professionals that there actually are out there. And again, you know, I speak particularly from a South African context, where we think in South Africa that psychologists and psychiatrists are the most well-known, and often then people don't actually realize that there's social workers, counselors, occupational therapists, etc., who actually are able to play a very important role in their recovery and yeah, just their mental health journey really. And then lastly is an SOS function. So I think, yeah, many people will be familiar with 24/7, 365-day-a-year emergency helplines. And that's obviously got your kind of typical de-escalation containment process to it. And that we see as the frequency to be much lower than obviously looking at the forest. And so, yeah, you know, I think you could maybe an additional layer that you could add onto here is looking at this proactive to reactive care from the forest up to the SOS. But I think from our side, we do really recognize that there's obviously a time and a place for different types of care and interventions. So yeah, before I move on, we can see on the right-hand side that there's this ongoing triage, assessment, and data analysis, which loops us back to that previous slide where I was explaining just this flywheel that we're really trying to create. And so, yeah, just to go slightly deeper into our forest, which is the core feature for engaging in the power of community. What we have within the forest is two different kinds of sessions. And so both of these sessions are still anonymous. So users are anonymous and it is audio only. So they can raise their hand to speak if they want, but they don't have to. They can basically just join a session and chat with the counsellor in the chat box, and then obviously chat with the rest of the mental health users that have joined that. And so the peer-led support groups is there wherein Panda users can host their own session. So it's basically to say, you know, I have got a life story that I want to share with people, and obviously then leveraging just this principle of universality and normalizing around getting people to join in and realize that they're not alone. Yeah, realize that, you know, they themselves can also be an advocate within the mental health space and a support for other people, and that really brings forth a level of meaning and engagement that we're seeing just to be so powerful for the mental health community that are engaging with the Panda app. And then we've got the expert-led educational groups. So yeah, these are obviously, I mean, we could summarize it in another way of being psychosocial education support groups. And it's really just, again, this entry point for users to connect with a mental health professional like I've previously explained. And so, yeah, again, reiterating that we're obviously using assessments and data insights to guide people across the severity spectrum. And so, yeah, I think perhaps less relevant in maybe, I guess, depending on the context, but something that we're really proud of that Panda's been able to do is actually the Informed Primetime series. And so, you know, this is kind of a third feature within the forest, but not, yeah, something that we, I guess, necessarily are putting on the previous slide, really just because it depends on context to context. But within South Africa, there's just been this incredible response of experts and influencers and leaders recognizing the need that Panda is able to meet. And so what we have is these people coming on to actually host sessions themselves. So more often than not, they're subject matter experts in something to do with work life or women or parenting or men. And so they can be actors, they can be comedians, they can be, you know, CEOs of well-known companies, they can be influencers or well-known psychologists, psychiatrists, whoever it is. Yeah, people come into the app, and we obviously then give them the exposure to our user base, and within the various different social media platforms, it creates a lovely complementary relationship for us and for them. And yeah, just really advocating for mental health and people to be getting access to resources. So yeah, that's our primetime series. And then I think, you know, something that Al mentioned is just looking at this mental health professional profile. So when I jump into the app, you'll be able to see that mental health professionals can register and they can set their own price, they can set their own interests, own profile pictures, etc. And so what we're really doing is just creating a platform to connect users to mental health professionals. And so yeah, you'll get some more insight into that. So yeah, this is our last slide, which looks at summarizing what we've mentioned, is that we're wanting to be providing quality personalized care with bearing in mind 4 key things: anonymity and accessibility, increasing utilization, proactive versus reactive support, and data first always. So yeah, we'll take your questions shortly. I'm going to just share my screen to give you a demonstration of the app. It shouldn't be too long. And then, yeah, really looking forward to hearing from you. So I think Allan mentioned that Panda is available globally. So internationally, wherever you are, you can download the app onto your mobile phone. You can just go into the App Store and it's free to download. And there's obviously these free functions within it. So please do feel free to go check it out. And if you have got any comments, any questions, we love to hear from people, because as you know, we get feedback, we're able to learn and improve. So yeah, you can email us at hello@joinpanda.com with any comments or questions. And so yeah, once you've downloaded the app, you can create your profile. But because I have downloaded the app already, it pops me up with this question of asking me how I'm feeling about my personal circumstances. And so I can then obviously have a moment to really pause and reflect on, actually, how am I doing? You know, it's this busy world that we live in, and it's just information overload, and people are so internally and externally distracted. Already up front, we're creating a moment to just pause and ask you a question on how you're really doing. And so yeah, once you've completed that, it pops you up into the forest, which is that key feature that we've been telling you about. And we can see here that it's basically got sessions on various different topics, and these topics are in response to the data that we're seeing. And so you know, as things happen globally, users respond to these things and then say, you know, I want to see more sessions on this or that or whatever it is. And so again, we're just able to remain really relevant and really accessible for our users. And then obviously, you know, maybe less so for this audience, but there's other features that you can say, you know, I want to remind myself about the session, I want to send it to someone, etc. And so, yeah, I think something actually that has really taken off, which is currently getting momentum, is support groups. So mental health professionals are coming online to host regular support groups for people. And then obviously, you know, if we even think of the AA, as Allan was mentioning, those kinds of different sponsors and having those sort of support groups, really just the applications for the forest and the use cases for the forest is really just endless and something that can be used. So yeah, that's basically looking at the forest. Then we've got the progress. So this is a demonstration app, so not typical of what you'd see in terms of tracking the mood, but you know, as we're collecting data, we want the user to be aware of that data themselves. And so yeah, we can see at the top there that they can track their assessments, and I'll show you where the trainings can get completed. And then obviously here, there's various different kinds of assessments that they can be completing. And once done so, there's obviously different recommendations and interpretations of their scores that they have. We've got a journal function where they can just collect different thoughts, experiences that they can put into one place. And then we've got our content section. So the self-guided content is a number of different packs on important issues and concepts and kind of coping strategies that people are able to watch the videos on, you know, read the articles, complete the activities like I was explaining to you. So yeah, that would be an example of one. So the mindfulness has got the dialectical behavioral therapy, how to slow down, different states of mind, etc. And then we've got our booking section. So the text-based chat support, we are an end-to-end solution. So within the one-on-one, we're able to provide the text-based chat support and the one-on-one virtual video sessions all within the app. So that obviously is an important factor just in terms from a user experience, whether you're on the mental health professional side or on the user side. So you can book a time, and then you can see here, I've got a South African profile. So these are obviously various different South African professionals that are here that have registered on the app. And so, yeah, that kind of, if we clicked on one, you'd be able to just obviously expand what is going on there for that professional and get some more information. And then looking at the my profile. So my profile is Gemstone. I've selected that as my username. So again, just to remind you that this is obviously an anonymous profile for people to create. So if I wanted to put myself as Kerry Howell, I really could and put a profile picture of myself. But obviously, you know, for the purposes of what we're trying to achieve, anonymity to be able to destigmatize is really, really important. And so you can create your anonymous profile there and select the keywords that you want. So yeah, I think that's kind of the highlight features. I want to, before I stop sharing my screen, I'm just going to check in with Elle if there's anything to mention while I'm on the app.
Okay, no, thanks. You've done a great job. I'm waiting to hear what kind of questions and comments people have. So thank you very much.
Yeah, no problem.
Thank you so much, Kerry and Alan. Very, very interesting. Looks like a very well-informed app. We do have a couple of questions, but I think what I'd like to start off with is something you mentioned right at the beginning, Alan, and you're talking about risks and functionality. And the app itself, it is dealing with those particular aspects of the mental health care. In what way is it assisting in dealing with the risk and the functionality? And is this a standalone treatment program, or is it recommended to be used in conjunction with the medication treatment or that kind of thing? I just want a bit of clarity. We're not necessarily suggesting that it's just the one or the other, but it's part of a broader picture. Is that correct?
Yeah, absolutely. Panda is not a doctor. It's not supposed to replace anything that that anybody you know, is getting treatment for at all. The way that we'd really like to see it being used is as a primary care intervention, and then as soon as you know, just in terms of entering the forest, downloading content, psychoeducation content, and then finding the care that you need. It's not in any way supposed to compare to treatment as usual. It's an access point, and there is primary care and there's triage within the app. In terms of risk and functionality, I guess, you know, the way that when I say it guides our philosophy, what we're doing all the time is we're thinking, how does our interventions de-risk a person's behavior, and how do our interventions in some way improve their functionality? So what we do is we obviously ask questions around depression and anxiety and you know, the most common kind of psychiatric or psychosocial maladies. But at the same time, what we really try and do is try and understand, who are our users? Who are they? And where are they, what kind of care are they actually needing? And in that way, what we're really trying to do all the time is to de-risk their behavior and improve their, I wish I could be a bit more coherent. All I'm saying is we're not trying to solve depression or cure anxiety or cure addiction. We're trying to make a person do less risky things and be more functional in their lives.
Absolutely. So it very much can be placed within the harm reduction, but also in the demand reduction sphere if we are looking at substance use disorder in its entirety. So there's several benefits that I can see in addressing those risk factors through an app such as Panda.
Yeah, I hope so. Yeah, I mean, yeah.
The other question that I would like to pose, and this is something that I picked up during the slides, it said they're accredited professionals. And even though I might know the answer to this, I'd like, why is it important that it's accredited professionals that are registered on the app?
Well, let me just say that our philosophy is that almost everyone has something of value. If you've suffered from a mental health problem, then I would say that you have value in terms of helping other people. And what we're seeing in other countries, like in the States, there's a huge drive towards peer support, where you have people who have suffered from a mental health problem becoming mental health peers and filling part of the gap for that demand for care and adding a complementary service to the other services that a person might be getting. And they can often help in the same way that a sponsor might help someone in addiction, just to kind of, you know, cross over those small bridges when you're coming out of active addiction and back into the real world, about sort of how to prepare for a job interview, how to dress for a job interview, where you might be able to, you know, just small things where you don't want to phone a doctor every single time, but you've got somebody to help you to transition. So we think that everyone has something of value, but what we've done in the app for now is we've made sure that everyone who is presenting themselves as a professional is either accredited or registered as a professional, so that we just can protect the public for now by making sure that a recognized national body has given this person some kind of accreditation or registration.
Okay, great, thank you. I'm going to bring Kerry back online because there's a question that I'd like to pose to Kerry. It's from Tanya Harris, and she says, what was all of the behavioral health services combined instead of focusing on just one thing? This is a great tool. However, what is the user's ability to utilize this tool in terms of understanding or reading the materials, that kind of thing? Kerry, are you there?
Roger, can you hear me?
Yes, I can hear you now.
Sorry,
yes.
I just, there we go. So I didn't hear the beginning of the question, so it's looking at the content. Can you repeat that for me?
So Tanya asks, what was all of the behavioral health sciences combined instead of focusing on just one thing? She says this is a great tool. However, she asks, what is the user's ability to utilize this tool in terms of understanding and reading? I think essentially what she's asking is user accessibility and how user-friendly is the app?
Yes, yeah. So I think, you know, what we are doing is really looking at what's called the UX, so the user experience. We've got a team, our development team, so software engineers that are both front end and back end, who are really dedicated to bringing out that exactly. So how do we make sure that it is a seamless experience for the users? How do we make sure that it's understandable, that it's accessible? And so, yeah, particularly with the content that lives within the app, that's basically being designed. Actually, what you know, quite technically we've done is gone more general, so a broad overview of what is available. So you know, something like mindfulness, something like relationships is a lot broader than looking specifically at what one kind of treatment or one kind of diagnosis or one kind of you know, life skills would be. And as we go along and get more and more users, we do hope to become more and more granular. But for now, a big part of the mental health sort of journey we're on is how do we give language to things that is understandable for users to be able to access, rather than keeping within the mental health professional or fraternity almost, where, you know, we understand clinical language, obviously our users don't. And so that's obviously something that's really important to us. I'm not sure if that answers the question, but yeah, maybe I'm misunderstanding. Sorry, Roger.
No. I think you have answered the question. I think you are basically you've acknowledged that, you know, there are two different types of languages we use in our professional sphere and the language that we use with our clientele, and they're not necessarily always the same. So I think you have answered the question because you've made it clear that you the app is focused on being as user friendly as possible for those accessing the services. The other question that I'm going to ask, so the tool is also is a AI stroke MI. So the data collection is really the goal of this tool, correct? What is this data to be used for? So the question is posed. Yeah, what is the data used for?
So really, the data that we collect on the user is really just to improve our services, to make sure that we are providing the right kind of services for what people need. And then as people go in and tell us how they're doing on either on a day-to-day basis when they first sign in every day, or when they do assessments, we can track and see what they've been using inside of the app. Have they been using the forest regularly? Are they downloading content, etc.? And can we see whether they're improving or not? Remember, we don't know who these people are. They sign up anonymously. We don't, beyond an email address, which could be, rogerd@gmail or whatever it is. We don't know who we know nothing about you other than the information you provide in terms of your gender and in terms of your age. But what we can do is we can say, we're not helping Roger. How can we do better? What do other people, given Roger's profile, what do they look like? How are they improving? How can we make our services better for Roger? So that's almost the major part of the data, of the use of the data that we collect. For companies, what we do, if they are our clients, is again on an anonymized and an aggregated basis, we can say that within your company, within your branches, let's say in the Western Cape, there is a lot of anxiety, more than we'd expect, of females between the ages of 25 and 40 about work-life balance. So instead of calling the whole company out for a seminar on communication or bullying in the workplace or gender identity or whatever else it might be, we can provide that company with information about what is it that people have told us that they're interested in, which areas of their lives are they struggling with, and we can have these dedicated campaigns to help those people have more meaning at work, basically. And so that's what the data is used for overall.
That is fantastic. I think, and what we are aware of, particularly in the substance use disorder field, that there seems to be a high rate of dropouts after a certain period of time. So collecting data like that, I think, is an important tool in sort of managing the success or the effectiveness of particular interventions. So that sounds as if it would be a further benefit in terms of substance use disorder. It leads me to another question, Allan, and I'll pose it to both you and Kerry. The peer-led groups have been immensely beneficial in a live setting in terms of substance use disorder. So we talk about AA and NA and support groups and that kind of thing. In a live setting, they've been extremely beneficial in the past. So in terms of the virtual peer-led groups that you are offering, have you seen the benefits? Has there been do you have data to show that there have been benefits in terms of those you've accessed? And I'm not talking about only the substance use peer-led groups, but the other groups that you have been leading. Have you seen any of this coming through, that there's been positive interaction with these peer-led groups?
Kerry, I'm happy to take that, unless you want to try.
You go for it, Al. I'll add in if I need to.
Okay, thank you. Roger, look, it's a great question. I mean, I think that having been to a lot of AA meetings and NA meetings in my life, I think there's nothing quite like being in the intensity of that moment with real people sitting next to you, some of whom have been there for, you know, a number of years, and some of whom have just arrived today because, you know, they've decided today is the day to clean up. There's nothing like it. So we're not trying to replace that, but definitely what we are trying to do is to say, if you want to just kind of feel the waters out, if you want to enter into a community and just see what it's like to speak about it for the first time, you can do that safely within the app. When we have meetings around addiction, you can talk about it. If you're then traveling and you're in a different country and you don't have your usual group and you can't find a group, let's say in your language or whatever it is, you know, use Panda to get that kind of support. But if you have your regular home group, I would say, you know, keep going as much as you can. We're not here to replace that, but we're here to augment those services. And what we have happened with us and with other groups is that, for example, the South African Depression and Anxiety group have now got, I think it's 60 groups a week that are running virtually, not on the Panda platform, some of them are, but a lot of them are running on Zoom, where people are moving to this platform just for convenience, and they're either these closed groups, which is like let's say 8 or 9 people who meet every week to discuss, or they're closed open groups where you have a regular set of people, but newcomers are welcome. And I think it's just supposed to augment the services that are out there, not to replace them.
And I think that that's an important thing. I mean, you mentioned it's easily accessible, and you know, a lot of people travel, and sometimes, you know, it's not always available or easy to, in terms of cost to get to the group, that kind of thing. And using a mobile app, it adds to the experience, and it doesn't necessarily mean that, you know, I've got to wait 2 weeks or 3 weeks until I get to a meeting. I do have one that's online that I can also be part of. So I agree. I think it's a brilliant accompaniment, and it can enhance the user's experience.
And if I can just add to that, what we'd love to come out of this webinar, we at the moment do not have dedicated AA or NA or harm reduction groups. As Kerry said, you know, the more users that we get, the more granular we can become. But when we have run, you know, addiction groups before, we haven't had great participation, if the truth be told. So what we would love is for anybody who's engaging and who thinks this might be a useful platform to start running sessions in the forest, and they can just get to us by writing to help@joinpanda.com to say we're interested in running a group on a Wednesday evening at 7 o'clock. And let's see how that goes. And we can do an NA group, we can do an AA group, we can do a Naranon group, we can do, you know, we can do a tough love group, we can do whatever we like. We can have all different kinds of groups, but I would love to see you advertising that as an additional resource, and for people out there who are listening to run those kinds of sessions. And you know, what's in it for you really is, first of all, it's you can just do it because you want to give back, but the other thing you can do is you can also talk about your rehab or your treatment center at that time, and somebody who really enjoys what you're saying and likes your approach can then contact you afterwards. And it could, I'm not saying do this primarily for that, but it could be a very useful source for referrals, or to just develop a wider network.
And you're broadening the reach. I mean, you are really making it more accessible for people to access those support groups. So, absolutely, thank you for that. I'm going to pose a couple more questions. So, thank you. The next question I'm going to ask is, is it required? Is it then required of users to evaluate the services that are on the app?
It's definitely not required. The way that we evaluate it is how much do people engage within the app, and what we've seen is that people who engage once generally engage 4 times a month. So that we are seeing what we refer to as stickiness, where a person likes the app and opens it up. It's not an everyday thing. It's not Instagram. It's not addictive. It's not anything like that. But what we do find is the more that people understand what the app has to offer, the more they do use it. So that is that's important to us, and that's the way that we evaluate it. Kerry, do you want to add to that?
Yes, I can add. I'll just to share that you know, the other co-founder, Alon Lits, that Roger mentioned, is obviously previously from Uber, and I'm sure, you know, if you're familiar with the Uber app, you really see how they're constantly seeking the feedback of the end user. So from a tech perspective, there's a whole lot of different means within the app where we are wanting the users to rate how was the session, rate how was that video, rate how is that. And so that obviously is just in terms of a very obvious data point, a means of feedback.
Thank you, absolutely. I think that you know, it's very important, and particularly in the, you know, within a country such as ours, we have a deficiency in terms of the statistics that are out there. But you know, I think it's also important that we are able to track a patient's interaction with the program, and by doing so on an app such as this, you're not necessarily being you're not intruding on the individual's privacy, and you are also evaluating their engagement, which is not always easy to do on a face-to-face basis. The next question I wanted to ask is, and this is posed, how do you treat a relapsing patient, and up to what extent is it possible?
For me, the way I would answer that question is that, you know, not to sound silly, but relapse can mean so many different things. And for me, the most important thing when I was treating patients who are suffering from addiction or dual diagnosis issues is to get them back into some kind of treatment as soon as possible. So not to let that relapse, you know, become something that, you know, that really kind of gains momentum. And again, I think that the app can be very useful with that, is that if there were groups, let's say relapse prevention groups or AA groups or NA groups, then people could join one of those sessions every day, and you know, you wouldn't have to wait for a meeting. You could go onto the app. Hopefully you'd be able to find a forest session or create your own, or request a forest session on relapse and get into it. But we need more engagement, and that's really what we want to get from you guys today, is that if you would engage with us and you would start to run sessions in the forest by contacting us, then we can have relapse prevention groups, and we can get people into those kind of treatment, that relapse treatment, as soon as possible.
Absolutely, thank you, Al. I'm going to pose one more question, and then I'm going to hopefully close off. So the other question that was posed, sorry, there are two more questions. The first is, can Panda be used across countries?
Yeah, absolutely. We just opened it up about a month ago. So the only feature that can't be used in every country is connecting with an expert, just because we can't have South African registered professionals treating people in other countries. But you can join the forest, you can download content, you can do assessments. Yeah, you can engage with most of the free features of the app in any country.
And then the final question, Alan, and thank you for that response. The app seems to be geared towards the general public. Is the cost, considering the damage done to people's finances during COVID, is this app affordable to everyone?
Well, it's free. The app is free. You can download it now. Just look for Join Panda in any of the app stores. You can download it now. You can sign up as a user or as a professional. What I would encourage you to do is to sign up as both, to get both of those experiences and understand what it is that you're getting when you refer one of the people one of your patients. So sign up as a user and as a professional. It is absolutely free until that user requests one-on-one sessions with a professional. Then what happens is that whatever the professional charges, that's the cost. Panda doesn't make any money from that. But the services that Panda provides, which is the forest, the content, and the assessments, that's all free.
Thank you. And can you just remind me the email address again?
It's help, HELP, at joinpanda.com.
Okay, so anybody who'd like any more information is welcome to give you drop you an email, and you can you can take it from there. There's one more question that I think I'm going to post because it's a very interesting question, and then I'm going to close off. I'm sorry to keep you, but I think it's one that is really, really pertinent. If a person has to go into a rehab center, how can you be certain that they will listen? Do you have people on the ground that you can send to their home to encourage them to actually go into a rehab clinic? I think this is a multifaceted question because it looks at social work practice and psychotherapy and motivation and all of that. But I think the essence of the question really for me here is, in terms of the network of professionals, it's not just about the professionals that are there, it's also about the network with other professionals that you have on the ground floor. Is this correct?
You know, one of the things that we want to start providing again as we mature as an app is continued professional development, is developing a network, is understanding, you know, who has space for a patient, when the patient needs it, in which area, who does motivational interviewing, who does interventions, so that one has, you know, a really live understanding of who can provide what service when it's needed. This is a community app, so the more people that join it, the better it becomes. And like I say, it's free. So please, you know, sign up, and by you signing up, you're making it better for everyone. There's no catch, I promise.
Absolutely. Thank you. Thank you. Allan, thank you so much, Allan and Kerry. There's been a lot of queries from other countries in terms of how can I engage with the Panda app. I have posted that email address in the chat box, so please feel free to contact Allan and Kerry individually, and they can have a look at your specific requirements in those countries. But once again, I want to thank Allan and Kerry, and I think it's incredible that you have put this together in 18 months, and that there has been so much that you have put into it, and it really echoes what I was saying right at the beginning, and that there's been a lot of expertise and a lot of thought put into what is actually available on the app. So once again, I just want to remind all of our attendees that just you know, this was a webinar. This was just solely as an introduction to one of the apps that are available in South Africa, but we wanted to highlight the fact that, you know what, they need this kind of intervention, primary healthcare, mobile app, it needs to be informed by proper professional and a professional practice, and that it's not a fly-by-night sort of intervention. There needs to be a lot of thought and expertise that goes into it.
For sure. Well, we also want to say thank you so much for giving us this platform. We really do appreciate it. This is actually one of the first multinational platforms that we've had the opportunity to present on, so that was really exciting for us, and I hope that people found it useful, and that we see you on the app.
Okay, so I'm going to thank everybody for attending, and once again thank you to Allan and Kerry from Panda for joining us and presenting on the work that they have put in there, and just thank you to our attendees. It was really good to have you with us, and please feel free to get in touch with Panda with the email address that is posted in the chat box, and this is a ISSUP webinar, and as ISSUP we want to bring about or raise the profile of research and developments in the field of substance use disorder. So we are looking at all areas, and that includes mHealth as a means for providing the interventions that is necessary in substance use disorder. So thank you very much, and Allan, we will be in touch in terms of that way forward, and it's thank you so much once again. Thank you ISSUP Global and ISSUP South Africa. Thank you very much to everybody, and have a great day further. Thank you.